Just to give an idea of the power of the oral testimony, it helps us to locate what you have in your facility. But above all, it gives, a bird's eye view of what you can project for those levels that you are representing. As we were analyzing the questionnaire, it became obvious to us that there are some contextual issues that pertain more to one level than another. So please, if you are having a testimony for the SHCs or the tertiary, if there are recommendations that you feel will help, especially for that level, please can you also add it to the list. So right now on the list, we have achievements, we have challenges, we have lessons learned, things that you did well and it has been found to work, and things that you did and you found that you had to reverse or do away with them altogether. A few things might have happened that took you by surprise, that took the facility by surprise, whether the department that have to do with the supply chain or the entire facility, even in terms of even patient care. Please let us be open and as comprehensive as we can. And then I also mentioned the last will be recommendations, if you have any, whether for your facility or for that level. Thank you very much.
I remain Wazir Umar, the HOD Pharmacy, Yusuf Dan Soho Memorial Hospital, Kaduna. I stand to give a testimony on achievement, considering that we are in Kaduna State. Within 24 hours or 2 days, you get your products. But you have to go there with your vehicle and collect the drugs. But with this program now, all you need to do is to send your requisition, then your products are delivered at your doorstep. And with this, it's an improvement over the previous program. And another thing is the price. Quite okay when we started this program. There are some prices that were high. But later, my staff used to even come and say, Oga, are you sure this price is okay? Because quite okay, some prices are very okay. They are cheap compared to the former program. So it's a good thing, it's an achievement with this program. And another achievement I want to mention here too, they try to make it an all-inclusive program. What I'm saying here is that the DMA now selected some people from the facility to be part of the procurement committee. So it's like they don't want to do it alone. So they need our input when they are buying products. They want to avoid a situation where they will stock the DMA with things that we don't need. And this is an achievement. So they selected members from the secondary health facility and the primary healthcare facilities too in the procurement committee. And that is helping us a lot because we give them our own input on what to buy and they comply. So it's an achievement. The challenge is now. When we started this program, the major issue we had was the availability of some of the products. Sincerely speaking, and that's why I don't know whether as I'm saying the challenges, I will be making recommendations. I don't know, okay? There are some products that we consider very important. I don't know whether I should permit me to even mention some of them. Yes, like in my facility, for the past 1 month, we don't have injection furosemide. And there was a time I stayed for almost a month without IV flagyl. So, and that has to do because already in one of the presentations they made, up till now, they are yet to get minimum and maximum level of all the products in the DMA. And it's only when you have that, that's when you can have availability of most of the products we need in our facility. So if they can work on the minimum and maximum, and here I want to also say that because I was opportune to be in one of the programs, that's the former program, SDSS. Before the commencement of SDSS, what they did was to go around, even though getting consumption data is a difficult thing, but they do that, and before kicking off the program, they capitalize facilities with maximum stock. So it's only when my thinking was, before this program, they will capitalize our facilities with maximum stock, okay? So that by the time our stock is falling below the minimum, we'll get another order. But as it is now, we don't have maximum stock, and that's why we are having this OS on some of the items. But still, it's an improvement over the previous program. Another problem we are having is the issue of cash receipt. Some patients will even refuse to buy drugs simply because you will not give them cash receipt. I don't know, maybe because the former system emphasized on receipt, that patient must collect receipt even before they collect their products. That was the former SDSS program we are running. And some of them have that in mind, and if you don't give them receipt, they will say they will not buy the drugs. So the issue of receipt is sending patients away from our facilities. Some of the patients, because they say they need to go back and account, they have to present their receipt if they want to claim their money back. So the issue of receipt is a problem. Another problem we are having, the former program, I think I mentioned it yesterday, and it's worth mentioning again now. There is a way we reconcile. Anything I generate, I will see alerts. But with this program now, right from onset up till today, in fact, what I generated, I have it on paper, but I don't know whether that amount is in my sub-account or not. So there should be a way of reconciliation. Lesson learned. Quite okay, there are challenges. And I know in life, when you see challenges, you're not supposed to run away from them. You use challenges as stepping stone to success. With that, some of the challenges we had then was the issue, the program did not capture those on retainership. Captured NHIS, but we have patients that comes on retainership. So what we did, like Nokako, we have Nokako. They were not captured, and they said they want to continue to do business with us. So what they did now, because this program is cash and carry, so they will now bring their money. The MD say, okay, I as the pharmacist in charge, I should collect the money. So when their patient come, at the end of the day, the total amount, I will now send my staff with the money, they will go and pay, and then we'll continue to keep record. So that at the end of the month, whenever their money is coming down, we inform them to reimburse us. So it's our own innovation. And if you are doing the wrong thing, so you should tell us now to stop. Yes, it's our own innovation too, okay? Then the lesson too I learned, change, it has been said too. Nobody wants, maybe you are used to one particular system, and within a short time, something new comes, okay? But as much as possible, we should try and see that we do our best to see how we can improve so that things work better for all of us. Because it's not always easy, especially with the nature of the work involved with this new program. There was a time I tried sending some SMS message myself. The time it took me to send a message, especially when you have a precision with more than 5 items, it's time consuming. So I know, but it's worth doing, because at the end of the day, everybody wants to be part of success. If at the end of the day, we get our consumption and our patients are getting drugs, then everybody will be happy. We want to be part of the success team. And they say, no pain, no gain. So we are ready to endure the pain so that at the end of the day, our patient will also smile. So we will continue to do our best to see that, yes, this program stands to succeed. But naturally, human beings hate work. But we have to work for the program to succeed. Thank you very much.
The last bulletin, can you say something? Unintended, maybe because of this process, you discover something new.
Okay, as in serendipity. Maybe along the way, if something, something. I can't recall, but if I recall, if I'm permitted, I will still come and say something. Thank you very much.
Thank you very much. A round of applause for Pharmacist Nu. I think I have to vote him along with other people, and he won the vote within my heart because I know he's outspoken. Even when we are at the central medical stores, when you call me, I become G3. Because definitely what you tell me is something that may be very difficult to achieve, but I know can be achieved. Very difficult. He will tell you to your face. Thank you very much for that open testimony. The next is in charge of PSC, Ongwarimi. Yes. I will not praise her, but she's one of the best. Yes. I'm not praising you, Aja, but you are one of the best for so many reasons. I'm not praising you.
Hello. Good afternoon, everybody. I'm Hassan Baba, in charge PSC Ongwarimi. I want to stand on all the protocol. One of our achievements, let me start from the baseline before the achievement. Before the new transformation, we normally go to the SDSS essential officer in the local government to go and procure our drugs there. Some of the time you will call him, he will tell you that he's in the office, you go there, you will leave your work in the facilities, you go there and spend some hours waiting for him. Maybe he's in a meeting or he has not even arrived to the office, so you will be wasting your time in the facility. They will be calling you to come and attend to some issues in the facility. So it's a serious thing then. Sometimes their drugs are very costly. When you complain to them, they will tell you that you should go and sell it the way they gave you. So you don't have any other choice. They are your superior, you have to obey them. So these are the things we started with the formal SDSS. So the achievement we have now, the drugs are not too expensive. And the greatest joy I'm having is that they bring the drugs to my facility. They bring it to my facility, but before then, the first day they brought the drugs, they brought it very late. But with because it's just piloting, we are just starting. As time goes on, we complain, so there is no problem with that. The drugs are very cheap, they are affordable, and they will bring it right to your facility. At least the cost of going to SDSS, they have removed that. The cost of you wasting your time there while your patient are waiting for you in the facility, they have addressed that. You'll be in your facility doing your work and waiting for your drugs to be brought. And most of the drugs we requested, like 80% of the drugs, we get them. Almost more than 80, we get them. At least it's a great achievement. We have to clap for them for bringing that change for us. Then the challenges, I've already said, they brought the drugs late from the initial stage. Like 3 weeks ago, I say up to 4 o'clock, I was about to close, then he brought the drugs. So he was just smiling, the man that brought the drug, he was just smiling, Matron in charge, I smiled at him too. I said, at least 4 o'clock is a good time. So I collected the drugs, I kept it in the pharmacy. So it's a bit challenge then. But another thing, the greatest challenge is not all the drugs that we requested that they give us. At least the primary healthcare in charges here and the pharmacy can bear me witness of that. Like for the past 2 weeks, I have to call Mercy. The drugs we requested is not the drugs, all the drugs they gave us. I called for a pharmacy Mercy and pharmacy Josephine. I complained to them. Immediately from there, she responded to me that they are very sorry. But what Pharmacy Norma said yesterday, it brought to me a picture of what is happening in the DME. It's not intentionally they do it. Because he was explaining yesterday that he have up to 5 facilities that brought their requisition. So imagine that you have up to 10 patients on your head to dispense drugs. You know, it's not an easy thing. So it's not easy for them too. They are learning. By God's grace, they will get there where everything will be easy for us, for him to give this one, to give this one. So when he was saying yesterday, I was talking to my pharmacy. I said, okay, that is the reason we don't have our drugs immediately requested. So it's a big challenge, and I know they will work on that. Then lesson learned. Another achievement is this SMS. I'm very happy with the SMS. Immediately we close from work. If the work is too much for me, I close late, I take it home. After resting, immediately I will send the SMS. But when I started sending the SMS, I was doing so many errors, you know, change. We don't used to eat. So when I was doing error, immediately they will be taking my money. Invalid, invalid. So I spent a lot of money before I arrived there. I so much enjoy sending the text. At least it's easier for us, it's easier for them to come to our facility, especially those facilities that have security challenges. It's easier for you and me and them too. So in the lesson learned, I learned so many things that even with change, you know, it's very difficult for you to change what you are normally used to. For example, now you give a role, a commandment to your son. He's not used to it. It will take time for him to adjust. So we are like a children to them. So it will take time for us to adjust. So I have learned that with even the changes, you can change your habits. What you normally do, like the former SDSS, we know the crooked way that is attached to SDSS. But we thank God with this one, it's just plain, it's visible. There is nothing you can do that they will not see it. So please and please, I'm begging us, we the primary health facilities, we should make sure this change really change us too, so that we work together. That's all I can say about it.
Gaura is my name from Barodiko Teaching Hospital. I will start by achievements. Basically, achievements is not quite different from what pharmacist Nuhu said, because of a truth, the availability of the standard prescription has really improved a lot of things. Equally, with the what do you call it, third logistic or delivery of drugs, time wastage has really decreased. We also discovered that the prescription by brands has drastically reduced in my facility. We are a hospital that before this time, all prescriptions come in brands. But for now, it has drastically reduced. And then equally, indiscriminate prescription patterns has reduced. Before this time, I have doctors that will use 2-3 sheets to prescribe for one patient. And you see drugs almost 10 on one prescription sheet. But for now, we are having change in that, which is good. Challenges. Basically, challenges quite similar to that of my friend, pharmacist Nuhu, the cumbersome procedure. So that has increased the patient's waiting time. And that is very serious, especially for a hospital like mine. Most of the time, some of these patients, because they can't wait, they run away with our prescriptions and go to buy. And most people have talked about the prices being moderate, but sometimes we face challenges. There are some people that will come, you prescribe to them, they collect your prescriptions, they go to the market, buy it, come back and look you to your face and tell you, we got a difference of so and so amount. And it's like, it's a normal thing, I know, but sometimes it hurts, especially for somebody that has passion towards satisfying patients' need. Then there is an issue of NHIS. NHIS are a little bit peculiar because the procedures is cumbersome. And for now, up to now, we have not had any standard operational procedures for maybe payments of NHIS drugs, because I sent to get a procedure, because there was a time we wrote a check to the bank. The bank rejected the check, that it was not properly addressed. And that was sent to the DMA, but a lot of stories, and I'm yet to get the clear way I'm supposed to submit NHIS payments, because these payments come later. And I don't know if the DMA could help us so that we can achieve a smooth flow, especially with NHIS prescription. For now, I'm a hospital that sometimes gets donations. And the donations surprisingly come straight to us. Because right now I have donations from a company that they wrote directly to my facility. That's Nemet. They donated some tablets of Combantrin for a deworming exercise. I don't know how I can factor that in. I have been trying to, because if I say I'm dispensing, it will bring problems to me. And I cannot explain, because it will seem as if I am doing parallel importation, which definitely I am not doing. Thank you. The limitations. For a tertiary institution like my own, we have specialized drugs requirement by consultants. I keep saying it. Presently, the oncology department is coming on board. The psychiatric department is coming on board. I have a family medicine unit that has just undergone accreditation, and so many other units are coming on board. And sometimes it's difficult getting some of those specialized drugs. I know we have few of them, but some of them are technical because the cases varied. So if you can have a way of factoring specialized drugs like psychiatric, oncology, and others into the system, I think it will help us. Then one of the great lessons learned is with the SMS system. I discovered the SMS system, definitely we talked about it as being cumbersome, but sometimes you have a way around it. You have to look for a way around it. Yesterday when we were talking, it's like I was surprised when I had my name being the pharmacist that had the highest SMS. It's true, but the question is, how did I do it? It wasn't really me, but I had to look for ways of encouraging my staff. If you look at my hospital, it's peculiar. Amongst all the list of dispensers, I'm sorry, but it has to come out. You'll find out that only 2 of us are male. Female, almost 20. And they have peculiar requirements. You know, most of them have issues to deal with at home. They have children to take care of. They have sick children, sick husband, all these things. And you are telling them, yeah, it's true. You are telling them to bring these prescriptions home because that's the only way they can do it. In fact, 2 of my pharmacists took prescriptions home to fill in SMS, and their husbands warned them never to bring such things at home. I'm very serious because an unintended effect, because they just warned them, don't bring such home again. And I want us to look into it because as a way of motivating I had to do the SMS myself. How did I do it? I had to call up my children. Yes, that's true. I had to call up my children, call up some of my students, and motivated them. Come, this job has to be done. And with that, we moved on. And I was surprised I had almost 400. I think by now it should be 500 and something. That's the truth. So we have to look for ways around some of these things. I think that's about all I have for now. If I remember, I'll come back.
Thank you very much, Pharmacist Gora. Well said.
Yeah, please, just for me to mention something so that we won't forget. Hello, pharmacist now.
Gora.
Yes, please. Yes, about the direct donation to the facility. DPS is here, sir, and you remember we have a drug donation policy for Nigeria. So every program has to align with national strategies. So I think it's good, please, if we liaise with the DPS for everybody that's donating medicines to line up with national. Thank you very much. There's a national strategy for donation, and every drug company, whether local or international, has to blend. It's already launched. Donation strategy. Thank you. And guidelines.
Hello. You know, when you're doing something and suddenly, maybe big fish enter, what do? You caught everything. You have a very big fish. And I show you that this fish is not the one you just catch with a simple net. You need a bigger net to catch it. And when you catch it, make sure you maintain it there in your domain. If not, it will go. I'm pleased to introduce the entrance of our Honorable Commissioner of Health, Dr. Paul Manyadogo. He is part of us. He has been part of us, and I believe he will continue to be part of us. Welcome, sir. I will call on, on the testimony, I will call on Dr. Gajere.
On that issue of donations that you made, it's not right for facilities to accept donations directly, and that's why they were mentioning the national policy. So, and of course, now that we have a centralized inventory, it's not like you can't have it, but it has to come through the central. So DMA can receive on your behalf, impute the inventory into the system, and then you request for it. So there's nothing wrong with that. And then you talked about NHIS. We've been discussing about it. So what you need to do is that NHIS patients, when they come to the hospital, they pay 10%. HMOs are supposed to pay 90%. So what you do is that when you impute the prescription ID, the patient pays the first 10%. When you have 90% at the facility level, you prepare a schedule for that same prescription ID, and you can send the check attached to it. And that's what we told your colleague, that you have to prepare a schedule, because this current account does not accept funds from with names. It needs to go and align somewhere. And the only thing that makes meaning to the account is the prescription ID. So you provide the prescription ID again and pay the 90%. So you make up a total of that check that you had prepared with the schedule with prescription IDs. And you can send it to DME to send it to the bank, not through the SMS platform. Oh, no, we can talk about that later so that this will go on.
Let me start with one of the challenges we had, and it's just what the ES of DMA has spoken about, was the issue of National Health Insurance Scheme. Actually, we met in Kafanchan and deliberated on how we'll be paying the National Health Insurance Scheme fees. The challenges arose from the pharmacy department because of the work. It means they will have to quote the 10% and then later again attempt to quote the 90%. Because yes, the 90% will have to be paid with the prescription code. So we sat down and thought over it. We went back to our records and got an average amount of money that we spend on national health insurance on a daily basis, and decided to make that money available every other day. So what happens now, right on the spot, in front of the patient, because their money is sent to us off front. So the money is already with us. So what we do, the patient pays 10% there and then, we pay our 90% and it's cleared. And that is precisely what we are doing in Kafanchan now. We don't want, at the end of the day, we are struggling to do, they have a lot of work to do. When will they sit back and start calculating all these things? When, as the pharmacists from Malawi said, most of them are also women in Kafanchan. How do they go on with this system? And actually, it has reduced the workload and repetitions. So precisely that is what we are doing in Kafanchan now. We make sure, and any other patients are really seeing reality. All this 90% they thought it was a joke, but right in front of them they are seeing money. You are asked to pay 1,000 and then you pay 100 naira. 900 naira is paid and you see them collecting the money. And they are very happy with that. But if there's any other development that we can be advised otherwise, we'll be grateful. I just want to talk again on the lessons learned. The DRF and SDSS had a lot of challenges. And During the presentation at the beginning of this transformation project, we saw a lot of things that down SDSS, and that had to do with the issue of monitoring and accounting for drugs bought and the actual amount of money generated. So I think we should also learn from that and use it so that this project, we now have people that are supporting us. And so it may be easier for us. But what when they leave, how are we going to really learn from the lessons of the past so that we don't go back? And today we are doing stock taking only to realize that you send drugs to Kafanchan worth 2 million. Kafanchan has generated 1.5. Drugs available 300,000. What happened to the remaining 200,000 naira? So we need to actually monitor closely so that we don't miss it out and find ourselves where we have been. The unintended effect, I don't know whether this program was designed to actually sanitize our prescription pattern, but really it has done a lot on that. And honestly, before, even somebody in the lab, they would just do tests, bring out their usual prescription sheet and prescribe. We all know it, they do it. But now you can't do that in the facilities. You take it to the pharmacy department in our place, they will tell you we don't accept this. So my appeal here, the unintended effect has really taken place. And just like at the point in time we ran short of receipts, I think, with due respect, all efforts should be made that at no time we should lack these coded prescription sheets. And if there's anything that has made this program laudable and very acceptable, is the sanity that the coded prescription sheets have brought. Thank you.
And we'll take one more from the HOD of Pharmacy, Governor One General Hospital, Pharmacist Rebecca Bako.
Thank you. Good afternoon. All protocols being observed. My own comment concerning the new system is on the positive side. When we started this system now, I can see the level of commitment to our staffs. Everybody knows the duty is supposed to face, and they are doing it very well. The products that we get from the medical stores, the staff also are used to it. One day we were in the hospital, a patient brought one brand of ceftriaxone that she bought it from the hospital when she was on admission. So the staff there saw the brand and said they never had this brand before. So the woman insisted that she bought it from the hospital. Then they had to come to me. I said, we have not brand before, so it's not from us. The woman had to go like that. The issue of NHIS and the account and the MD, they are very committed to that. They make sure they pay the money, and whatever the amount is, they pay it after a week. And I'm very glad about that. I don't have much, in addition to what my colleagues have already said.
Thank you very much, Madam Rebecca. Please, I don't know, I want to go down to the grassroots. I want somebody from PSC to do something.
All protocol observed. My name is Jomai David, PSC Fadanka Goma. I don't have a different thing to say more than what the others people has already spoken. The only one that I want to contribute here is that the joy I have over this pilot system. Of a truth, there is increase of knowledge. Many of us has forced to sit up to do the right thing that is expected of us to do. I can remember before this pilot system, most of our staff, they neglected their job. When you ask them to do something, they don't take it serious. But especially the day that we have been introduced to this SMIS, in fact, it was a different thing in my facility because nobody is willing to be backward, especially when he spelled it out that they will deal with you according to your point. Come and see how they are rushing now. I don't need, in fact, before I talk too much, at times I find it very difficult. I tell them that I don't need that position again. To be in charge is not a cost. But now I need not to talk. You are on money duty. All they need is that everybody is rushing to see how much patient he gathered today. And all their effort. Now, you cannot even tell them that, what about your friend that did not even get a client? No, everybody is trying to see that he get a bigger point. Even when they don't even know the outcome of the point, what will come after it. Everybody is rushing. In fact, I don't talk now. Since that very day, I don't even talk. I will go to work before I reach there, they finish everything. And then I rest. I think it's a joy. And it adds more knowledge. In fact, we learn many things. It's not easy for somebody to add D, Q, D, star, this and that and that. Most of them, they don't even know how to send the SMS text. But now, everybody knows it. You cannot even tell them. I think this is the little thing I can add. Thank you.
Thank you very much. I believe this is not a little thing. She cheers us up. And at times when you're going to the market to buy something of 5 naira, go with 10 naira. You'll be surprised with what you buy again with that 5 naira extra. You see now you've been hiding yourself. I noticed you, Jim Michael. It's all right. Dr. Gajire is here for us.
Thank you very much. My Honorable Commissioner, you're welcome, sir. The ES and your staff, our IPs, my directors here, my colleagues, and fellow field workers. I feel greatly honored to stand before us just to give this contribution. I think the essential things have been said. But as the landlord of the DMA, I'm sure you know that the DMA is within my jurisdiction. So I'm their landlord. So I am particularly happy that this is happening within my backyard. So definitely I'm the best person to say something about it. It is good when DMA called us about a year ago and started introducing this issue. All of us were skeptical. But honestly, as I stand before us now, I can say that yes, if you can dream it and keep focused, you can achieve it. We were skeptical. We said all sorts of things. But the scheme is not yet perfect, as we've heard, but it is achievable. I think the essence of this meeting is to appraise the scheme in the past 1 year and see how, if possible, we can make some corrections or even include the other facilities that are not included. And there are some hiccups. As the pharmacists have spoken, the fellow clinicians have spoken, as administrators in the field, my colleague has spoken too, but there's something that has been worrying me in since this program started. That is the issue of the D&E that was removed. Of course, you know that we do a lot of social service. There are a lot of poor patients coming, indigent patients coming. Some cannot just afford. In the old scheme, there was a markup to take care of them. Now that markup has been completely withdrawn. When we have patients with us, it is impossible unless I use my own running cost to attend to them. But if something is going to be free, somebody must pay for it. But I don't think that I should be the one to pay for it. His Excellency should think of how he can introduce the D&E scheme into this system so that through the DMA, these patients can be attended to. Two, even the pharmacy itself, the pharmacy department, is left with no kobo to attend to the daily needs of the pharmacy. Am I supposed to buy broom for them when I don't get their money? I think this is the thing. They sell their drugs into the bank, and the pharmacist is asking me to buy broom and omo for him or for her. And if I refuse, it is another different thing. Please, some running cost must be given to the pharmacists. Should be given to the pharmacy department through this, so that they will be able to run their departments. This system is technology driven. The issue of the control tower that has not yet been set up, and the issue of computers in the facilities. Some of the staff are not really computer literate, but as somebody has said just now, many of them are eager to learn. But these systems must be given to us in the facility. At least a laptop or a tablet, so that the person on duty can just look at the price list, scroll through, just type 001. What is 001? Or let's say paracetamol. What is the code for paracetamol? And it comes up. Otherwise, using the sheets to go through them, that is what increases the waiting time for the patients, and some of them will leave and come back. But honestly speaking, I think some of the drugs are now more affordable. I remember telling my pharmacy, she can attest to that. I went down with the flu and I went to buy a cough syrup in the town. Honestly, I was in the hospital at that time. So I went and bought it. I bought it at 1,000 naira, and it was 800 in the pharmacy. So honestly, this is, I told you, isn't it? Yes, I came and told her. I said, yeah, some of the drugs are now much more affordable, but we can do better. Please, I would suggest that we do a stepwise inclusion of some of the facilities in the local governments. For now, we have only 28 facilities in this, 5 secondary facilities and 23, one from each local government. But we have 255 in the state, isn't it? Plus 31 secondary facilities, including Barauduku. If I think I'm a little bit skeptical, again, just like I was in 2017 when I first came, but the task is great. Why not think of including some of the bigger secondary facilities and 1 or 2 more from each local government, one from central, northern, central, and southern part of the local government, 1 each, to go with the present comprehensive health center that is already included, and let's see how it goes, so that when we are able to come and assess again, maybe in 6 months' time, we can decide to include all the others. In this way, I think we will be making much more headway in the program. Once more, ES, thank you very much. I wish you the very best.
It just occurred to me now about the envelope, the dispensing envelope. I hope I'm saying our mind. We have just challenges. Like we, the in charge, we have to remove money from our pocket to buy dispensing envelope and leather that will put the drugs for them. Thank you.
Josephine, are you here? Do we have dispensing envelope and bags? We have dispensing envelope and bags, but you have to request for them. Yes, you see, in this system, it's not like you get what you didn't request for. Whatever you want, put it on your request, because that is what generates what the DMA will buy. But we have them. Their facilities are already requesting. Yes, so I think that was a communication challenge.
No, thank you for all of these commentaries and these testimonials. I like that you're talking not just about the achievements, but about the challenges. So that's the way we can try to improve this transformation pilot. But I would like to hear for some of maybe the officers in charge from the PHCs, maybe even the secondary facilities. You have a lot of supply chain systems here in Kaduna. You have the vaccines that are delivered in one way. You have your donated program drugs delivered in another way. HIV comes in another way. You have now this one with the supply chain transformation initiative. Which ones what are the pros and cons of each one? And maybe you can help me explain this. Like, which ones are, what aspects of, say, the way that RI commodities are delivered do you like, do you not like? And how does that compare to this?
What are the things that you like in other systems and what are the things that you don't like, or just compare and contrast? You have HIV, vaccines, nutrition, malaria, other programs, and you have this transformation project.
In comparison between the pilot system and all other free programs, in fact, how I look at it, before, when we make prescription, there are a time that some patients cannot afford to pay all. But with all this free supply that we get from malaria and other organizations, it helps us sometimes. During the prescription, if the patient will receive at least 3 or 4 items, and it happens, we get 2 that is under this free, it makes them feel happy and give them joy, and they pay less. Even though the drugs are not orderly very cost, yet it's reduced some costs again, and they like it.
Where I understand the question, this transformation is more easier because they bring the drugs to our facility. Why the vaccines? Almost every Monday I have to give my RI money to go and pick the vaccine to the facility. At least for us to, for immunization people to bring the vaccine to the facility, at least it's more easier for us. Like other drugs, the HIV, they bring the drugs to the facilities. So, but the immunization, they don't bring it. Every Monday, she have to go to the cold chain to go and get vaccine and have to give her money from my pocket to go and get the vaccines. So at least this transformation is more easier than the other one.
I remain Esther Jani from PSC Dadu. My own opinion is the same thing with her own. Like the malaria in my own case, we used to go to the facility, to the local government and collect it. But this pilot one, they bring directly to our facility. It's safe. The other ones is time consuming, but this one is save time.
Well, somebody said under the challenges that the local government medical stores are now passed. So it will increase the efficiency of the system. You get your drug directly in the medical store, then you have to go to the local government medical store, then you collect from the local government medical store. I think that is what used to happen what is happening in other programs. But this time around, you are getting it direct. So it will save a lot of time.
We also want to know the paperwork. How do you compare the paperwork of other systems to this system? Paperwork now, entry of whatever, your record keeping and...
In this program, honestly speaking, this program is well understood, well educative, and also is well understood. And again, in paperwork, with this pilot program, is quite okay and easy because we are now in the facility or we are going back to our house to send the SMS. But in the others, it's not good as this one. Why? Because you have to sit down. Maybe you can create a fake data and send it to them, and they will not bother if it is fake or good data. So this one, there's no way you can send a fake data. So that's all.
I like that.
Afternoon all. I'm from PSC Fadan Kamantal. In fact, this pilot kind of a thing has brought more knowledge, and it could be easier if we have more manpower. Because we lack manpower, you will do this, you will do this. This thing is waiting for you, another thing is waiting for you. So we are pleading on behalf of PSC's colleagues that please they should increase manpower because we will break down if we don't raise more.
It's good, as you said. You are not going to fall down, don't worry. Just put in more effort. And if you look at it, this system has even lessened your work. One, somebody from Kudaru will not drive all the way to Lere to collect drugs. You are in your own place. That has reduced your work, isn't it? SM and the SMS platform, you are in your office. Somebody said he even took it home. You are not sharing the job. I think it's something, somehow the time has been reduced. We understand there's a problem of human resource for health, and the state is doing everything possible to see that it is taken care of.
I would like to stand on existing protocol. My name is Thomas Kasim Muhammad. I work with Hajjah Gambo Government Hospital Zaria. So many things have been said by my colleagues about achievements and challenges. I think they have said almost everything. But one thing I think I need to mention it here is the issue of this price list. Almost all the time when these price lists are sent to us, we used to have some issues with them. Like the one that was sent in December, we collected some items from the DMA, and it's like the price of one particular item it doesn't agree with what is in the price list. To be specific, augmentin injection 1.2 gram. In the price list, it's 189 naira. But in the research invoice, it's about 900 naira. And this price list is in the public domain. I think I saw it in the governor's website or something. Somebody can download this thing in his asset, come to your facility, how much do you sell this thing? Maybe when you costed it, you can now call somebody and say you are inflating the price. So what my advice is this: before you issue out this price list, it has to be doubly checked. You check it properly and make sure that there's no any issue with them, no any problems with them. Like the one that was given to us in, I think, January. So many items are missing in it. So many items are missing. Exactly. And we have to be using the other one in December to get some of the codes. But apart from that, I think it's a very good thing. We are really seeing transformation. We are really benefiting from it. We have more time for our patients. We don't come to pick drugs anymore from DMA. And then we don't spend money in that process again. So it's a very good thing. We should uphold it and make sure it succeeds. Thank you very much.
Good afternoon. I thought I would mention only coded prescription. I want to remind us that these items that are attached to commodities, I mean the necessities for dispensing the commodities, the coded prescriptions, the polythene bags, and envelopes, you ought to treat them the way you are treating your drugs. When you are taking stocks, you take stock of these items. When you are writing requisitions, you request for them along with your health commodities. Don't receive health commodities today and call us tomorrow that you need prescription booklets. Send them together. Thank you very much.